Good morning, everyone. I am Dr. Chip or Dr. Yingmanee Jermthanes. Okay, I am an orthodontist a while ago, and I've been using aligners since 2010, just like Fiona said, and I've been treated more than 600 cases with aligners. Of course, some has failed, but many, many more worked really, really well. So all of the cases today will be used Smartee GE because it's the first product that I tried. And with the GE, I can treat many, many kinds of cases. The first case is this case, crooked teeth, severe crowding, and she's a growing patient. This is her. She came with her mother. Her mother needs to drive 2 hours to our clinic. They come from other province, but because in that province, there's no dentist who's done the aligners or the one that they can trust. So they ask their friends because she's in the entertainment business. She's one of the young actress. So she asked around and then they found me. So they came to me 2 hours drive to here. Her mother said, because the agency said she has very, very crooked teeth and needs to be fixed as soon as possible without fixed braces. But when I saw her for the first time, she had braces on the top of her teeth. So these records, I had the x-rays done and I had the photos and I had her intraoral scan, but then I removed her fixed braces and then did another photos and the scan. The girl said that she didn't happy with the fixed braces because it rubbed her mouth and when she acts, when she has a pin around her mouth, she doesn't feel comfortable. Okay, so I said, okay, then aligners would be a good choice of the type of the treatment. So let's have a look at your teeth. She's in the late mixed dentition. So you have the upper E's, both left and right side. And the severe crowding areas are at upper canines and the lower right canines. The bite is very deep. The deep of a bite complete. And the molar relationship is class 2. The canines are class 2 and still partially erupted for the upper canines. Okay, and extraorally, if you look at her from the side, she has quite thin lips. We can call that the thin upper lip, and the nasolabial angle is quite normal to obtuse. And when she smiles, she showed normal teeth show. So I planned for her at this stage, at this point, just try to prepare the space for all the adult teeth to come through to the alignment. It's just that for now. When we have a look at the radiographs, OBG shows that the 7s are erupting, the upper 5s are erupting, and both of them are in the correct positions, and all 8s are forming. And lateral ceph shows that she has coital class 2 with a low angle. The upper and lower incisors are a little bit upright. And because she's growing patient, so when I see her teeth, when I see her films, I know that she will grow more. So actually, she's not class 2 to me. She is class 1, but will be class 1 in the future if we can unlock her lower jaw, let the lower jaw grows naturally, because now they are locked by the dip of a bite. So the treatment objective now is just to relieve the crowdings. We can use expansion, proclination, and distalization all together to relieve crowding. Okay, And because we know that we always steal the space from the big size of the E's for the 5. So I know that I can distalize the 6 and also distalize the upper 4s as well to the E's space. Of course, the upper E's was then to be extracted before we put the aligners for her. So when we did the scan, we sent all the information to the lab, and then I sent patient for the extractions of the upper E's. And also, I gave her the retainers to wear to protect the space and also to prevent any movement of the teeth because she had braces before, remember? I just removed her fixed braces. So we need the retainers to keep the spaces and also to test her as a, she will be the aligner users. So to test that if she can manage to wear the aligners, the retainers, 22 hours a day. Now we come back to the treatment plan. So we will try to distalize the upper 6, distalize upper 4s, open the space for the upper canines, both sides. The incisors will be proclined and also the arch will be expanded. So this is the prescription that I sent to the lab. Correct everything to class 1. And also about the dip of a bite, I want to have the intrusion of the anterior teeth and the elevated premolars. And the overbite actually should be partly corrected by the proclination of the lower incisors as well. So we have the relative intrusion. And of course, the molar distalization needs to be done and proclination as well. All right. And this is the 3D plan. I came back. So I distalize the upper 4s into the E space and distalize the 6 backward. And as you can see here, the upper canines doesn't move because I told them that do not move the upper canines. Do not involve the aligners to the upper canines because they're partially erupted. I want them to erupt naturally because when teeth erupt naturally into the provided space, they always move faster than we move them with the aligners. When the aligners arrive, I have to trim them myself to cut the upper canines out of the aligners. So as you can see that the plan mainly just procline and distalization and expand. This is her after 5 months. Everything's not fully corrected, but much better. Look at the upper canines. They come down, keep coming down. Whenever they have space, they keep coming down themselves. And we need to do the refinement for her at this stage because her upper right second premolar has been erupted and the aligners doesn't fit anymore for her. So we need to do the rescan. So we did the rescan and we continued the same treatment plan. Continue the distalization, continue the proclination, continue the expansion to try to relieve the crowding. And also the incisors were intruded as well. This is her after 5 months. Okay, this is the refinement 1 that we continue the same tooth movement, same plan, just to prepare the space, but only that this time I included the upper canines because they erupted quite well and close enough to the occlusion. So I included the upper canines and of course the upper right 5 that came up. Okay. The IPR, I did mention to the lab that I want a minimal IPR as possible because she's still very young. She's only 12-year-old, and I don't want her to feel any sensitivity or feel any bad about having the aligners treatment. So we minimize the IPR as much as possible at this point. So this is her after the refinement 2. Okay, we need to do a rescan because the upper left 5 has erupted. And again, she cannot wear the aligners fit again. So this is 9 months after the first refinement. This is a refinement 2. So as you can see now that there's a button on the upper left canine because during wearing of the aligners during the refinement 1, the upper left canine doesn't come down. It's been off track. So I cut the aligners out to have the button cut out, and then I put the button on. And then ask patient to wear the elastics from the canine to the molar. But on the other side, there's still a precision cut for the elastics to be worn. Okay, it looks a little bit, higher than the other side actually, but actually that the upper right canine still fits in the aligners. That's why I still leave it the way that they are. But actually, as we can see now, actually the buttons on the tooth works much better on the extrusion, as we all know that. So we did the refinement 2, but this time, if you look at her mouth now, extraorally, when she closed her mouth, she has to try to close her mouth because now all of the teeth are too procline. And look at her face. Now she has more the adult size of the face and head size, and the nose and the chin and everything has become more adultly. So I think now it's time that we can use the IPR to retrocline the upper teeth. And because look at her size of the teeth, it's too big for her. She has a very small face, very narrow face, but very big teeth, white teeth. So we did the IPR for her, both upper and lower, to retract the incisors and to reduce the proclination. And also, of course, we try to reduce the overbite more for her. So here. So we did the IPR from anterior teeth and posterior teeth, okay? And the lower incisor we did as the last refinement already. So in this refinement, I didn't do the IPR in the lower anterior teeth. So just the top, upper anterior teeth, and the posterior teeth. Okay. And this is her now, almost finished. She's still under progress. She still has more aligners to be worn. All the 7s are coming, but they all look good, looks aligned, and occlude with the opposite teeth. So I think we just continue with the aligners that she have, and then the rest of the story, debond and retainers. Okay, look at the face. From the side. Now she towards +1, and she can close her mouth naturally, and her smile is much better. So this is from the beginning, refinement 1, refinement 2, when the upper 5 erupted, upper right 5 under refinement 1, upper left 5 erupted under refinement 2, and then the progress. So it's been around 2 years because in this case, I want to finish the case when she's fully grown, or at least, past the peak of the growth already, so that I am sure that this is her final phase. I always treated my case to not just the dental, not just the teeth. I treat that the teeth must match the face as well. So I'm not in a hurry in this case. Normally, for young children, we may allow patients to wear aligners only for 7 days or 10 days. But in this case, I asked her to wear 2 weeks, 14 days, because I want to wait until I want to finish you when you have the adult face already full grown. Okay, and she understands. So it's been around 2 years, and now she will finish soon. So only minor tooth movement to be corrected. And look from the before the treatment, and now her lower jaw has been grown forward, obviously, like dramatically. Okay, and I still can keep her upper lip not too much backward. Okay, because at first, when I sent this case to the lab, they suggested that I should do the extractions for her, like full premolars extractions. I said no, because she's class 1, she's not class 2, and her severe crowding is not that severe actually, if we align her teeth well. So this is the result. Okay. The next case is also another severe crowding case, but in the adults. And this case, we've done the extractions. This is her. She's now 40-year-old. She has class 1 teeth, but on the class 2 skeletal. And the right canines, both upper and lower, were extracted. The left canines, both upper and lower, are severely crowded now. And her lower midlines off to the right a lot. And upper midline shifted to the left a little bit. And her chief complaint, of course, it's difficult to clean. I said, I believe you, it's very difficult to clean. And it looks very crooked. The difficulty of this case is the root divergent of the lower lateral incisors and the first premolars. They are very like in the opposite direction, and the lower right lateral incisors are severely rotated. Okay, so this case, I chose to extract the most malalignment teeth, which is left canines. It's because the right canines has been removed already. So if you want the symmetrical extraction, then I chose the left, both upper and lower canines. Okay, combined with the IPR and the expansion. Okay, the IPR, because of her, again, big front teeth, and also the expansion because of the arches is quite narrow. From the OPG, it shows that she has number 4A tooth impacted, and we agreed to leave it because it's been 40 years, but of course need to be observed every 6 months. And right canines, upper and lower, are missing. And look at the condyle on the right. It's very, well, pretty much resolved before. And that's when I mentioned this to her, and she said she doesn't have any symptoms or anything. I said, okay, good. But if you have any symptoms during the treatment, we might need to stop. Okay, so she agreed. And lateral cepts show that actually she's class 1 with a high angle. Okay, and here. And actually, upper and lower incisors are a little bit upright from the ceph. But of course, we don't treat the X-ray. We don't treat the ceph value. We treat the patient. So when she's small, she feels that her front teeth are proclined. So we will move them back. So the treatment plan to extract the left canines, upper and lower, correct upper midline to straight to the face, and also with the lower midline, go back to the left side. Expand both upper and lower, and IPR, anterior and posterior teeth, close out the space, correct the angulation of the lower lateral incisors and first premolars. So this is what I sent to the lab. That, patients said that there's protrusion of the facial profile and wants to correct that. And the bite is deepened, so I want the intrusion of the anterior teeth. And of course, we need to correct the midlines. And the extractions ordered to extract the left canines, both upper and lower. Okay, let's see the 3D plan. So as you can see that they did the tooth movement really, really well. They moved the lower incisor one by one. That's what I always want. One by one, keep the space between each incisors until at the end close all. That's how we can control the such a small teeth, the lower incisors. And the power arms were put on the right side to control the root divergent of the lower right lateral incisor and the lower right first premolar. So I was very happy with the plan. This is her after a while. And we did the refinement at this stage because the lower left lateral incisors, as you can see, it tipped. The crown tipped distally, and the root still at the mesial side. And upper right first premolar also off track, cannot move the root mesially as well. So here, so as you can see, the midline is much, much better. Okay, now the main problem is to continue to correct the midline and correct the angulation of the lower lateral incisors and the first premolars and control the roots of the upper right first premolar and close all the space. So we emphasize on correct the tipping of the lower teeth. And to do that, I did put the power arms on the lower left lateral incisor and the first premolars to, control the root divergent there. So finish on the left side first, prepare the space for the right side, and when the right side is ready, have the space for teeth to move into the space, then the power arms will add later. Okay. And this is her during the refinement. She said many more aligners to be worn. And look at the angulation has already been corrected. Okay, look very nice. Now we're moving to the, but if you look at the upper right premolar, still very tipped. Like that. So the midlines also better, and the lower left angulation of the lower left lateral incisors are much better. This is progress 2. When we move on to the right side, okay, so we remove the power arms on the left side and we start to move the right side. So we put the power arms on and put a power chain between the hooks and change every month. Now the midline is corrected, see? Very beautifully. Okay. And now we've gone to refinement 2. At this stage, as you can see, it's my mistake that I didn't put the attachment to hold on the lower left lateral incisors. So look at it now. The roots tip back again a little bit, but not as much as the beginning, but tip back. So actually, after we correct the roots, we should put the attachment on back to to control the position of the teeth. But look at the lower right side. The lower right lateral incisor now are very good. Remember the first visit is almost 90-degree rotated. Now it's rotated back beautifully. But the problem is the right side, the extraction side, we can call the old extraction side. So I said, the premolars doesn't want to come forward at all with the roots. So I use my finger to feel the bone and the roots there. We have the, little bone between the lower right lateral incisors and the first premolars, same upper and lower. And I can feel the roots very prominent already. So I told her, okay, for the right side, for the left side, no worries. The roots will be corrected beautifully. I don't worry about that. But the right side, I will try to move now with a gentle force. I don't want to move with the power chain and the power arms anymore. It's too dangerous because you don't have enough bone there. So that's what we did. Now we try to move the right side with only the attachments, not the power arms and the power chain anymore, because I want the force to be gentle, very gentle, not too much, because I'm afraid that the roots might come off the bone. And if they come. If they're not, just leave it for now. And she agreed. She doesn't want to have, She also noticed that now I can feel the root. It's very prominent than before. So yeah. And the left side, I'm sure I can control with the attachments. That should be. So that's her at the beginning. That's her at the moment. Okay. She's still in the progress, and overall it only takes 15 months. But of course, this is the case that the patient needs to come to see us quite often, every month, to change the power chain. Or you can choose to ask them to wear the elastics themselves. But to me, I'm afraid that, they will pull the power arm off the bone. So if the patients within the area not have to travel far, far away, then why not come every month to check the tooth movement as well? Okay, the summary of this case, the old extraction space leads to insufficient bone, so have to be reminded all the time that be careful of the old extraction space. The auxiliary components is very, very useful. The power arms, the buttons, and elastics. Okay. The attachments need to be put to hold the position of the teeth that moved from far away or difficultly moved to the current position. So you need to put the attachments on. And the careful plan of tooth movement and anchorage consideration is very, very important for this kind of case, for the extraction case. Okay, we come to the third case. This case is a class 3 case, spacing. And this patient, okay, he's Thai, but he doesn't live in Thailand. He works abroad, but around Malaysia. So he can come back like every 4 or every 6 months, but last visit's quite long. So this is a kind of a case that we have to plan really carefully because we know that patients cannot come in to have the teeth checked that often. Okay, now he's 28-year-old. He's class 3, molars, canines, relationship, incisors, skeletal, everything class 3. But good that we have the spaces. Spaces can help us to correct his class 3. The overjet is -2, the overbite is 2 millimeters. From the X-ray shows that he has the upper left third molar that hang down, of course, order to have it extracted before wearing the aligners. And lateral ceph show that he has skeletal class 3, low angle, and actually the lower incisor is already upright or retrocline. So the treatment plan, of course, non-extraction. We try to level the upper incisors because look at the overbite. It's because the upper central incisors are hanging down, lateral is up. So when we level them, we should have a good overbite. And also we retract the lower incisors back, closest space, correct the class 3. So this is what I sent to the lab. Close all the spaces, correct the cross bites. And retract, close all the spaces. Upper left 8 will be extracted. Okay, so here the 3D plan. Some IPR has been performed to facilitate the class 3 correction. And of course, class 3 elastics is used. But as you can see here, there's buttons on both upper and lower molars because, let me try to show to you again. Because see, there's open bites on the 6 already. So I want them both to, close everything. So it's a class 3, I call it class 3 triangle. So class 3 triangles. Okay, to pull everything together. And this is him after. So as you can see, he wears the aligners really well. The space closed really well, but still have a little bit of a space and have a little bit of the settling of the posterior teeth. See, even though I put the buttons on the upper and lower sixes, it's still open at the back. It's because it hits interference at the anteriorly. Okay, so now he's on the refinement 1 to correct the rest of the problem, but there's not much to do. Only we should finish within a few months to close everything up, and then that's it. Okay, now we come to the last case. Okay, this last case is class 1 crowding. Adults, and she feels that her front teeth stick out. And because she said, my buccal corridor shows too much when I smile. So when you have the black area on the side of the mouth, And the front teeth a little bit stick out. Of course, it looks very forward because it's very prominent to be seen when you smile. So she's 32-year-old, class 1 canines, class 1 molars, deep of a bite, a little bit large of a jet, crowding both upper and lower. And look at the narrow upper arch. It looks like almost the omega shape. Very, very narrow from the canines to the first molars. So we can expand them all. Okay, and look at the x-ray. So she shows that she has a 4/8 horizontal implanted tooth, normal condyle. Okay, for this case, I ordered this one to be removed. And after the patient discussed with the surgeon, she also agreed she doesn't want to have it to the impacted tooth, so we have it removed. And the condyle is good, and lateral staph shows that she has skeletal class 1, normal angle, and so the plan is to not extract anything, expand, keep expanding, expand, expand, expand. Reduce overbites, align the teeth, and retract the incisors back. Okay, so expand upper arch around 3 millimeters, intrude upper anterior teeth around 3 millimeters, obtain 1 millimeter of overbite and 2 millimeters of overjet. Expand lower arch around 2 millimeters, relieve the crowding. That's the plan. So the 3D came back, of course, a lot of the expansion going on. Okay. And the IPR and the retraction of the incisors. Okay. And when you have a lot of the expansion to do, don't miss to put the big attachments on the buccal side to control the torque, or you will have the tip out of the teeth. Okay. Okay. This is her after 7 months. Okay. Because she's the internationals, she's a teacher in the international school. And when I ordered the 3D plan, as you can see that I have the bite ramps in the upper incisors, and she said she cannot speak clearly. She cannot teach her students to speak clearly because she cannot do it herself. So we stopped the upper aligners at where there's no, the last one that there's like 28. The last one that, has no bite ramps, and keep wearing that one. But we continue with the lower aligners to finish the lower, and then we do the refinement again to expand more. Because as you can see at this stage, the upper arch can be expanded a little bit more on the right side. Okay, the left side looks good, a little bit more on the right side. So this is her after only 7 months. Looks much, much better. She's very happy with the result. And look at the attachments that I put on the buccal side on both. Only the one that has the crowns that I didn't put on because it is zirconia crowns. You cannot put the attachment on or they will come off. See? So when she smiles, we can see less of her buccal corridor. Before, we can look at straight to the 7, like from the front teeth up to the canine, and then we can see her 7. But now we can see as it should be. A little bit of the premolars, and now we cannot see her molar anymore. She's very happy. And on the side, the teeth look a little bit back, which is good, not too much back. But back to have the beautiful smile. Look at the buccal corridor. This is very important to explain to patients as well, because sometimes patients says, I have the stick out teeth, it stick out a lot. I want them to go back like a lot. But if you look at the whole mouth, sometimes because you cannot see anything on the side. We move the front teeth backward a little bit, not that much, but it goes back a lot. Now she's on the refinement because, like I said, we stop the upper aligners at number 28, and then we continue the lower until she finished all of her aligners, and then we did the refinement to continue with the upper without the bite ramps. So it's just a little bit of more IPR and correct more of the overbite. Okay, because we stop the intrusion of the upper incisors. Now we're back on the track. Retract everything. And now she's still in the progress. Thank you for your attention today. That is all today for the lecture.